Welcome to today's webinar on food insecurity. This webinar is a part of our Special and Vulnerable Populations webinar series. The last webinar we held was on LGBT health, and then the next webinar we'll have at the end of October will focus on rural homelessness and the process of segmenting a population, understanding the health disparities of that segment, and designing interventions that address that disparity. Today's webinar on food insecurity will be recorded and available to you and your colleagues after today. We are going to mute the phone lines during the first part of this webinar and then open them up at the end for question and answer time. During the presentation, please use the chat box over on the right-hand side of your screen towards the bottom. And you can send us messages and questions during the presentation, and they will be monitored, and we may answer some of them as we go. Otherwise, we'll save those to the end of the presentation to answer at that point. I think that is it for our logistics. Please try not to put us on hold when it comes to the question and answer part. And I think that's it. So I would like to now hand over the facilitation of this webinar to Alicia Atalame. She is our Social Determinants of Health Manager and has been very instrumental in developing this webinar and doing a lot of work with our clinics around food insecurity. Alicia.
Thanks, Claire. So we have some great expertise here for you guys today, and I'm going to start by walking us through the agenda. The first part of the webinar will be focused on a little bit of an introduction to the topic of food insecurity and why we're focusing in on that with the Special Population Series. And then from there we'll hear from Lynn Knox, who's the Clinical Outreach and Trading Coordinator at the Oregon Food Bank. And Lynn's work is focused specifically on connecting with clinics like all of yours. So it'll be great to hear from her. She's going to talk to us about the food insecurity screening process in the clinical setting. Then we'll hear from Sylvia Ness, who's the Health Promotion Coordinator of Integrated Clinical Services at Multnomah County Health Department. And Sylvia is going to be sharing a bit about some of the fantastic food-focused interventions going on at the county that they've put in place to support their food insecure patient populations. And then from there we'll move into a Q&A session where you'll be able to submit any questions or comments that you have for our great experts here today. And we also have some questions that we might put forward to get a good conversation discussion. So with that, I think we'll get started. So why a focus on food insecurity? So as Claire introduced me, I'm the Social Determinants of Health Manager here at OPCA, which means that my world is really focused on social determinants and supporting all of our community health centers in either beginning to assess and impact social determinants that are impacting the health of their patients or continuing the great work that they're already doing in that area. And I think a lot of the conversation that I have with folks has to do, when folks express concern around starting to look at social determinants of health, has to do with the fact that they can feel really big and broad. And it can feel, I think, sometimes difficult or challenging to figure out how best to dive into taking on and looking at and impacting all of these factors that impact our patients outside of the four walls of the clinic. And food insecurity is, I think, a really great place to start in terms of looking at social determinants of health because it is fairly actionable already. So, you know, in the clinic we can screen patients for food insecurity and we can refer them to community interventions and resources that are already in place. For example, like the Oregon Food Bank, food pantries, etc. We can also start to think pretty concretely about what it might look like to put into place interventions within the clinical setting. And as I said, we'll hear a little bit more about what that might look like down the road in this webinar. So the next piece you'll see here is that food insecurity has a direct impact on clinical health outcomes. Another piece of working in the realm of social determinants is the fact that it can sometimes feel like what I call a long game, in that we're really looking at things that have a really big impact in a lot of direct and indirect ways over a long expanse of time. And it can sometimes be difficult to draw a direct line to what we might put in place to address social determinants and the impact that we'd see on our patients' health outcomes. But again, food insecurity is really unique in this way because we can really easily tie it directly to the clinical health outcomes that we see in our patients, like hypertension and obesity and diabetes. And we know also that it has an impact on the cost of healthcare. So, for example, a good example that I think illustrates this is that as folks who are on SNAP benefits, or food stamps might be a term that you're familiar with, as food benefits run out at the end of the month, we see that H1C levels can be harder to contain, which could lead to an increase in emergency room visits and obviously higher costs associated with that. Next, we've gotten a lot of feedback that our community health centers are really interested in focusing in on food insecurity. So both CHC leadership and the staff at clinics have expressed a dedication to focusing on this topic and recognition of the fact that it's really having an impact on the patients they serve. And you all have expressed wanting our support in starting to look at that more in depth. Last is the fact that food insecurity screening is on deck as a possible future CCO metric. So it's currently on deck for 2017, and obviously this would be a great opportunity for us to further focus our attention there as we lead up to that. So what does the data tell us? I want to first say thanks to Lynn for sharing this data with OPCA. It's been great to get a sense from the Oregon Food Bank and the information they have there. So 2013 data shows that 15.8% of Oregonians identify as food insecure. And we'll get a little bit more into that breakdown on the next slide. 66% of individuals age 60 and older who are eligible for SNAP benefits, and again, SNAP benefits are food stamps, are not receiving them. So those are folks that are eligible for these resources and identify as food insecure, but really aren't getting the help they need in being able to address that. And then 50% of Oregon children qualify for free or reduced lunch. That made a big impact on me, 50%. That is a pretty big percentage, and I think really paints a picture of what food insecurity looks like for Oregonians and their families. So this, I'm not going to spend too much time on this, but you will get this presentation after the webinar today, so you can delve into it a bit more on your own. You'll see this is just a breakdown on food insecurity by county, by Oregon counties, and it has both the rate and the number of individuals that identify as food insecure with the state totals there at the bottom. So with that, I'm going to turn it over to Lynn, who's going to talk to us about food insecurity screening.
Good afternoon. I appreciate this opportunity to share some of the work that I'm doing around the state with clinics with you. It has been a very rewarding activity because clinic staff are surprised to find out that it's really fairly simple and pain-free to implement food insecurity screening into your clinic workflow, and that there are lots of options and approaches that are all very valid. We're trying to create a bit of a learning community of different approaches throughout the state, but there are at this point almost 200 settings where this is being implemented, and absolutely no two are exactly the same. You as healthcare providers have this unique opportunity where you connect with people sometimes on a regular basis, sometimes irregular, but are in a position to talk to them about this connection between food and health that we are learning more and more every day about how critical it is and how it is driving the poor health outcomes of huge segments of our population. Because of this rise in diet-related disease, the Oregon Childhood Hunger Coalition, which is made up of healthcare professionals and anti-hunger activists developed multiple different educational and outreach tools for healthcare personnel to try and assist them in working with patients and in understanding the importance of good nutrition to health. When we did a survey of practitioners across the state, 80% said that they supported the idea of food insecurity screening in their clinic. The barriers they saw were issues of concern about time and that they didn't have the resource information to refer people. They didn't want to find out that people were food insecure and not have anything to help them. So we used that to develop this program and develop the appropriate tools to make it simple for you. We did a pilot at the 2 Dornbecker clinics in 2013 where we learned a lot about implementation using the 2 validated questions that are derived from the U.S. Census and are being used all over the country in a consistent manner to identify food insecurity. And then the Oregon Food Bank developed a 1-page electronic health record system compatible handout that is localized by county of all the resources that are available to people who are food insecure to get food assistance and education about nutrition and gardening. Then we provide a variety of the options and examples of how it's happening all over the state. There's an algorithm for children who are food insecure that we can share with you, standard ICD codes that you can use to record the information, and then there's even a continuing medical education course that is available at childhoodhunger.org. So I encourage you to check that out and use it if you need a couple of CME credits. The screening is being implemented into clinic workflows in basically 3 different ways. The questions we find are best asked in writing. We've done it both ways, and you see almost a 30% higher reveal of food insecurity when there is a question asked in writing, as opposed to the medical assistant or a nurse or somebody working at the clinic directly asking the question. So we try to look at how do you provide these 2 questions in writing before the patient sees the clinician, either at check-in or when the patient is put in the exam room, then you give it to them. Sometimes it's incorporated into other surveys or assessment questions that are provided by the clinic on other social determinants or other health status issues. Sometimes it's a standalone. It's up to the clinic to decide what works for them, but we do stress that this is very important information for the clinician to have at the visit that day, because there are many conditions that you get a false identification of symptoms if you don't know that food security is part of the or food insecurity is part of the picture. ADHD in children looks very much like food insecurity. When a child has been hungry for weeks or had a very poor nutritional mix that may include really heavy processed foods, really heavy sugar, just overall poor diet quality for a period of time, you may get a false indication that this is ADHD, put the child on medication that's not going to do any good and may even do harm. The same with seniors who have that, as Alicia said, very high lack of use of food stamps. They have incredibly high rates of depression that may be, in fact, the result of food insecurity and poor nutritional diets that give them symptoms which look like depression, but if you took the simple route and helped them improve their diet, might clear up without medication or extensive kinds of counseling. This is so important to get that information to the clinician, get it into the patient record, and then the clinician can, as part of the after-visit summary, print out that one-page handout on local resources that we provide for every county, and we encourage the clinic to try and identify a specific staff person, maybe a community health worker, maybe a health navigator, maybe a trained volunteer, or even an intern from a nursing school close by that can meet with the patient right after the visit with the clinician to discuss and review this list of resources. It takes about 10, 15 minutes to sit down with that patient, review the list, make sure they understand the list and how to access things. With the first resource that is new, we encourage the community health worker or whoever to go deep, go to that website that's represented on the handout. If they are not enrolled in SNAP, and the information there will tell you if they're eligible, then right then and there, fill out the form with the patient so that when they leave the clinic, they have accomplished something that makes a difference for their nutritional health. You're taking a few minutes to move that forward for them is really the difference between it being done and not being done. Just handing somebody a piece of paper, as you probably know, does not mean that action will be taken. And so we will work with you to identify the staff that you can find at your clinic who could take the time to do this, or find people from the community that we can train to work with you and build a partnership to provide that kind of support to patients right then and there in the clinic after the visit. Then at the next visit, the patient has a few weeks or months later, the clinician can see in the electronic record what happened and follow up and say, hey, it looks like you applied for SNAP benefits when you were here the last time. How's that working? Have you been able to improve your diet? If not, would you like to talk to the community health worker again? So it's very flexible in terms of how you set it up, and we'll work with you to find the resources that make it possible to do a good job of this in your clinic. Once a clinic starts getting involved in screening their patients, I think there's a process that happens of becoming more and more aware of what a serious problem food insecurity is in the community, and we often see that clinics want to get involved and do more. You've got a list in front of you right now of some of the veterans of this work that have been doing it a year or more throughout the state, and they all, again, do it differently. There are dozens more that are in the process or are also veterans. I'm just giving you a range of the different organizations across the state to help you see the breadth of possibility and the breadth of support that this approach is having. Once you have implemented screening, if you want to do more within the clinic setting, the Oregon Food Bank is very eager to work with you and possibly do things like schedule cooking classes at your facility or across the street in a church, to schedule gardening classes, to do on-site produce distribution, or even we're working with multiple groups to develop a Veggie RX or food pharmacy program that allows the clinician to give out actual prescriptions for produce at a certain dollar level, take it to a local store, and redeem it there for a certain amount a week. There are all kinds of possibilities for you to go deeper and get involved, and Sylvia's going to talk about some examples here in Multnomah County of clinics that have taken those steps. And we'd love to work with you, and you can contact me at any time because it's my job to help you make this simple and easy to determine the food insecurity of your patients.
Thank you so much, Lynn. This is Sylvia Ness. I'm going to be sharing with you some of the different programs that we're working on at the Multnomah County Health Department. And just to give you a little bit of context about the Multnomah County Health Department, we run 8 different federally qualified health centers, and so the different programs that I'll be talking about are programs that we're instituting at one or more of these health centers. And you might be a little bit curious about why a health department would be working around access to and preparation of fresh vegetables. I'm not ruling out fruits here, but we seem to be focusing more on vegetables, so it says fresh vegetables. We know that a lot of people in our communities aren't eating well, and we know that because our clinicians and our different staff talk a lot about their frustration around what happens when they counsel clients to eat well. And they report that it's really, really frustrating for them to know that the right thing to do is to talk about eating well and to know how many barriers and challenges there are for many of our clients to do so. A lot of these barriers are around access, and I use the word access to mean at least 2 different things. So when I say access, I mean both financial access, which we certainly know is a challenge and a barrier, as well as geographic access. And it might be surprising to think about Multnomah County having geographic access barriers, but there are many places in the county that are either considered to be food deserts or that are very close to being food deserts. So this is an issue both in urban areas as well as our rural areas of the state. Another issue is shopping for and preparing healthy meals really is a skill set, and I don't think we always necessarily think of it in that way. But for a lot of people, we know that our clients, after many years and sometimes their whole lives, or in some folks' instances, it really is generational, So sometimes the skill set that we used to pass down over the years really has gotten lost. And so this is something that we also need to be paying attention to, is figuring out how to get people the skills in terms of actually preparing and shopping for healthy meals. So I'm only going to talk about the first couple of points that you're seeing on this slide, but we are doing some other things at the county. These are all pretty new programs that we've instituted within the last 3 to 4 years. And so I wanted to give you an idea of the spectrum of these programs. So for instance, the picture that you're seeing up on the screen is a picture of staff at our Mid-County Clinic who have volunteered to plant and grow and deliver produce from the garden that's situated at the clinic to our clients. And this particular garden produced about 100 pounds of food last year that was distributed in the lobby to clients. So 4 of our health centers have these vegetable gardens. We're also doing demonstrations, cooking demonstrations about how to use vegetables in different ways. At one of our health centers, we also work with the Oregon Food Bank to host a Seed to Supper class, and that class is having people learn skills around actually gardening their own food. And then finally, grocery store tours are something that we've developed a curriculum for, and those grocery store tours really focus on both shopping on a budget, so looking at things like unit pricing, reading coupons, as well as reading food labels. So now I'm going to go into a little bit more detail on 2 of the main projects we have been focusing on. So CSA Partnerships for Health is a pilot project we're doing at one of our clinics this year. And it is a partnership of many different organizations. And primarily, it is a partnership between ourselves at the county and Zenger Farm. Zenger Farm is an urban farm that also happens to have a focus on education and social justice. So they are really great partners for us in this work. What happens is when a client signs up for this program, they are signing up to get a box of farm fresh vegetables for 23 weeks during the summer season. And that means they're becoming part of a CSA. And if you're not familiar with that term, CSA means Community Supported Agriculture, but essentially it is just a box of vegetables from your farm. In our case, the CSA runs from June through the first week of November. And it's enough vegetables for about 2 or 3 people for a week. So people come and they actually pick up their vegetables at our health center. They come every Tuesday afternoon. It's a market-style CSA, so as you see in the picture, it looks a little bit more like going to a farmer's market. People get to walk through the line, they pick out their own vegetables, and in that process, if they've never seen that vegetable before, there are people from the farm on hand who can answer their questions, who can suggest different ways of preparing that vegetable. There are also recipes that they get in a newsletter. And one of the things that we didn't necessarily set out to do with this program, but is proving to be the case, is that we're also really forming a community. And members have reached out to share recipes with other members. Those recipes are going to the newsletter. We're also featuring members every other week or so that members get to know one another. Another partner that we have in this particular program is the Knight Cancer Institute, and they have provided grant funding so that we can actually subsidize these shares. That was one of our main aims, was to make this something that could be affordable for as many of our clients as possible. And through the grant funding with the Knight Cancer Institute, we've been able to have a sliding fee scale so that people pay anywhere between $5 and $20 per week for their share. Switching gears a little bit, the other program that we have been doing that I want to talk a little bit about is our partnership with the Oregon Food Bank. They deliver a class called Cooking Matters. And Cooking Matters is a curriculum that actually is delivered all over the nation, and the Food Bank is the organization in the state of Oregon that provides this class to Oregonians. This class we have featured as part of our CSA program as well. So for members of the CSA, one of the opportunities that they get is to participate in this class. And in addition, we also offer this class at all of our different health centers one time per quarter, so we rotate it around to all of the different health centers. So Cooking Matters allows us to do a lot of different things with our clients. It's a very robust curriculum, and it allows members, or participants rather, to learn about making healthy eating choices, to work on shopping healthy on a budget, to practice making recipes from scratch, and to offer people a healthy environment to try new ways of eating and being around people socially who are also trying to make changes for themselves. And I think this last point is a really important one, and I think any of you who have worked with clients who are trying to make changes in their lives know how difficult it can be for them to try to make changes. They're going back to their home environments, they're going back to their peer groups where people are not necessarily trying to institute these same changes. So that can be a really big challenge for people, and I've really seen that the people who participate in this class enjoy having their peers around them who are also trying to make changes. They enjoy learning from those people what some of their challenges have been and how they have overcome them. So that's been a really powerful piece of these classes. It's the learning that goes on peer-to-peer, as well as the learning that goes on between the facilitators. So, and just realistically speaking, the way that these classes are set up is that there are 6 weeks of classes, and participants come in for 2 hours a week. And they actually, during the course of that class, it's a pretty jam-packed class. So they learn different nutritional components. They learn things around knife skills. They learn how to store food, prep food, and they actually make a meal and eat it together during the class. So there's a lot going on in those 2 hours. And they have homework as well. So at the end of the class, they do get to take home a bag of groceries that are the ingredients for the main meal of the class. And when they come back, they have to talk about how that went. So they have to talk about what they made, whether their family liked it or hated it, what they did with those different vegetables. And so they get to actually work through the challenges in their real-world setting. And I want to kind of finish off this piece by talking about one of our client stories. Brian was a participant in a Cooking Matters class over a year ago, and Brian came to us with very few skills around cooking. In his words, you'll see that he couldn't even cook an egg. And he was very literal about that. We saw him struggle through the first couple of classes. But now Brian is actually preparing meals for his roommates. He talks about going to the grocery store, and he's a coupon clipper now. He's a big label reader. So he's made some amazing strides from the moment that he walked into that classroom to a year later. And you know, all of our clients come to us with really different experiences and really different skill sets, and I think that's the beauty of some of these interventions, is that, as I mentioned before, they learn from each other. So we have people who already really know how to cook. We've had people come to these classes who ran their own catering. That doesn't mean they necessarily know how to cook in a healthy way. And so for some people, it's the nutrition piece of this that's really important. And for some people, it's really the actual cooking and knife skill sets that they're there for. So I wanted to talk for just a moment about some of the challenges and opportunities of this work. It certainly is challenging work, and there are some barriers to trying to implement it. But I'll get to the opportunities in a minute. Planning this work takes a lot of coordination and time. And I wanted to actually get into what is going on with some of the CSA pieces so that you'll have a sense in reality of what this looks like. So for the CSA, there's actually one site coordinator, and I'd say that from probably about a month before we launched until about a month or two into it, this project is probably taking about 25% of his time. So it's a lot of time. We have one global coordinator who liaises with partners as well as the health center, and that's about 25 to 50% of my time. We have a staff advisory group that meets for 2 hours every month, and we've been working on this project for about 1.5 years. So go into this with your eyes wide open. It definitely is something that you should know takes a lot of work. The second piece that I think has been quite challenging is around member recruitment. And this little graphic that you see on the right, that's the workflow for a referral. It's not important that you know exactly what's in that workflow. This is really just to illustrate that it's complicated. So there are at least 3 different positions that are involved in this and many different steps. And we didn't expect it to be this complicated. So we actually had to put this down on paper in order for us to be able to understand this. Funding on a sliding scale subsidy. The funding piece, we were very lucky to get that grant from the Night Cancer Institute. It is about $9,000 for 25 participants for 23 weeks. One of the reasons the cost of this is so high is that most of the participants did come in at $5 on that sliding fee scale. And that's something that you don't really know until you get into it, where your members are going to show up. But that indicates to me the need for this, the fact that so many people slid all the way to the bottom of that fee scale. And then finally, getting staff on board. We really underestimated how much work that piece was going to take. There are always going to be people who are really excited about this work and people who are kind of your champions. So those are the people that we've definitely been working with. But for a lot of other staff, they don't necessarily see this as something that is vital to the health of their clients. And so asking them to take the extra time to make an appointment referral did not work all that well. So one of our strategies in this pilot year has actually been to open up 5 spots on the CSA to clinic staff. And so we're really hoping that as we move forward into our future years, that those people will be big champions of this work. So what's promising about this work? I've been really floored to see how excited people can get about vegetables. It really is not something that I anticipated. I knew that people would want their vegetables. I did not expect people to show up every week saying, radishes are my new favorite vegetable, and now they're my grandkids' new favorite vegetable too. The same woman came back 3 weeks later and said, well, fennel is now my favorite vegetable. So it's really been a joy to work with people who are clearly excited about the produce that they're getting. People are eating and liking brand new vegetables like fennel that they've never eaten before. They're telling us that they'd never be able to afford this without this program. They're involving their partners, their children, their grandchildren, and their friends. They're learning budgeting tips for shopping. They're sharing their own stories and recipes. And as I mentioned earlier, an unanticipated piece is really that they're creating new support networks through their participation. We have a member who sometimes picks up the share for another member who's not always able to make it out of her home. We have members who have come to cooking classes and spent the whole cooking class sitting with another member's grandchild so that the member could participate in the cooking class. So this is really something that builds community as well as making access available for fruits and vegetables. So I wanted to share a little bit of a future vision, and I want to acknowledge that while there are lots of people at the county who probably share this vision, this is probably my vision for moving forward. So I think a great future vision around this work is that all of our health centers will connect clients with fresh, affordable produce, that all of our health centers will offer some form of skill building on making healthy, affordable food choices. This is not cheap work. We're going to need to find other partners in our community, whether they're insurance companies or community benefactors that will step forward and help us support this work financially. And finally, and maybe most importantly, I would love to see our health centers function as places of wellness, places where people come to attend yoga classes, Zumba classes, they come for walking groups, they come for resources around food, and maybe they come to join a CSA. Thank you so much.
All right, so we're going to go ahead and open up the lines for questions, because we would like to know what questions you have for Lynn and Sylvia around food insecurity. And you can say this verbally on the line, or you're welcome to type into the chat box.
Hi, this is from Coast Community Health Center. I'm actually not on the web part of the webinar. I'm just listening in on the phone. The two questions for food insecurity, are those on the slide?
So yeah, I was wondering that. So Lynn, the questions that are the food insecurity questions, I don't think we actually saw what those questions were. You want to just tell them to?
Right. I don't have them memorized, but and I apologize, I don't have them with me. I'm glad to take your name and send them out, or we can just post them or send them out all together. But it's basically, have you or your family had difficulty affording healthy food in the last 12 months?
Yeah, so I actually do have the official questions here, and yeah, I can read them. So the first one is, within the past 12 months or 30 days, we worried about whether our food would run out before we got enough money to buy more, or before we got money to buy more. And then the second is, within the past 12 months or 30 days, the food we bought just didn't last and we didn't have money to get more.
Okay, so thank you.
Other questions do you have?
I have a few questions. On the two-question thing, what's the health literacy level of those? I know that because it sounds like you're saying, Lynn, that it's really important to have them read them and write is it read it or write the answer? And has that ever been a problem?
Well, we have it available in 13 languages, okay. And it has not proved to be a problem. You know, if people need support, it should be available at the clinic, yeah. But they're being used all over the country with all kinds of like populations. So I don't know the literacy level, but it is geared towards a low education population.
I do have a question from a chat. It says, it seems like there's an effort to improve access to healthy foods, but what are some of the challenges to ensuring that populations in food deserts have equal access to healthy foods with transportation barriers in mind?
Every community that has either pockets considered a food desert or is a food desert in itself is employing different approaches to that question. It's something that needs a full community effort. The healthcare sector, the emergency food sector, the social services, government needs to come together. Often churches take a lead in this work to help identify solutions. The city of Portland spent a lot of time and effort trying to recruit grocery stores to certain areas of the city and offered some incentives. It didn't actually pan out very well, but that may have been because it was heavily during the recession that they were doing that work, and maybe it would work better in a different time and place. So there just are all different kinds of efforts. Markets, more like farmers markets, have sprung up in some places. We've been able to, based upon input from health centers, schedule a special produce distribution to a place that is identified, either be it a clinic parking lot or a community center that has been identified as a food desert. And then there is just announced a federal program that's going to start of home delivery to SNAP recipients of groceries. So that is definitely something to watch for.
Hi, this is Sylvia. Thanks for the question. I think that the question around transportation is a really big deal. One of the reasons that we chose to do the CSA partnership at the clinic that we're doing it at is because this clinic is located in the middle of an area that does not have a lot of access to healthy foods. And we chose to have the drop-off site be at the health center because it's a place where people are going anyway. And so that is just one way to remove some of the barriers of people being able to get to a place where healthy food is available.
So Sylvia, at the beginning, Alicia was talking about how access to food can address some clinical indicators and move those in the right direction. I wonder if you're making connections between your programs and moving indicators that payers would be interested in.
Yeah, that's a great question. So this year, in our pilot year, we're really focusing on figuring out how to make this work, and the logistics is around how a program like this works, how you do the referrals, who is what we're calling an ideal client to participate in this program, some of those pieces. We are doing an evaluation of this program, so stay tuned for the future. We're really hoping to be able to put some of those other health outcomes on in additional years if this particular year pans out and we see that this has been a good thing for our clients.
And then at the food bank, we're working with a few specific clinics to identify patients with conditions like diabetes, or there's one clinic where the entire population of pregnant women has a history of gaining more weight than is healthy. We're putting in place measurement of food insecurity and then interventions to educate and support their access to healthy foods, and then tracking the results. So there are some efforts in that way. I also urge people to look at the Wholesome Wave website, where they have done some excellent evaluation of their veggie prescription program to look at health outcomes of people who are involved in that.
I think specifically BMI is one of the health outcomes they've looked at.
And blood pressure as well.
I have another question. This is Lori. How do you guys document the closed loop referral? So when you refer somebody, when you identify a food issue and you identify the resource, do we know how many people make it to actually have an improvement in their nutritional status as a result of that referral, or make it to the?
That's part of the reason we urge people to put it in the electronic medical record, is so that the clinic can make that connection, get that feedback. It's not feasible, except on a very small demonstration scale, to have all the community agencies that might be involved provide that kind of information and feedback. But the clinic is the one place in the EHR that can truly be tracked.
We just don't know that data. We don't have clinics currently that we know how well that's working.
Currently, clinics, as you know, are overburdened and have a lot to do, and until it is mandatory because it's a new performance metric, it will not happen.
We have one question from the chat from Linda. The question is, has the Oregon Food Bank and Multnomah County Health Department consider mobile food vendors, i.e. fresh veggies/food trucks, to the, let me scroll down, to the food desert populations that might not be able to access the health center?
We've considered it. As you can see, we have a lot of projects that we're working on right now, so it might be something we work on more in the future, but we kind of have our hands full at this moment.
And there are multiple communities where the food bank is doing mobile distribution. It's not something that in Multnomah County we've prioritized because of cost, but there are 2 mobile food distribution vehicles in Multnomah County that are operating, and we could use more. So it's an issue of cost. You know, there are various communities where the CCO has even contributed to a mobile food distribution vehicle. I hope there will be more of that.
And I'd say, this is Sylvia again, when we were looking at doing that, one of the things that we were finding is that that takes a lot of planning with a community too. And I think on the level of an entire health department, you might be able to do that. But from the perspective of a single health center, that's a lot of work. And where we've seen this not work very well in certain situations, where some of the mobile vendors have gone into a community thinking that they would have a captive audience and it would work really well. But if that community doesn't actually want that food, or it's not food that is appropriate culturally for the community, or a variety of other different things to take into consideration, sometimes those projects don't work out as well as we think they might.
I have a question. This is Claire at OPCA. Do community health workers tend to do any work around food insecurity and health eating? And what does that potentially look like?
In many places, community health workers are the folks that, after the patient has met with the clinician and received a handout, that sit and review it with them and help them figure out what's a new resource and how to access it. I've done trainings at the State Conference of Community Health Workers and have a whole curriculum that's been delivered to some of training programs for community health workers. So yeah, they're a critical resource.
And this is Sylvia. I've seen the same thing. Our on-site coordinator actually at the clinic that's doing the CSA Partnerships for Health is a community health worker, and we would not be doing this work if it weren't for him. He's been vital to all of this work. And the group, the planning group that came up with all of this work, has several community health workers on it. So, I mean, they're really at the front line of this work.
So another thing that we talked about that I'm interested to hear both your perspectives on is, obviously there's some variance in the interventions that clinics can put in place. You're going to get different outcomes with those different interventions. So can you talk a little bit about the impact of, say, the least amount of work intervention, like giving a patient with a food pantry that they could go to, and some of the more in-depth resources that Sylvia talked about? You know, how effective is it for someone for a clinician to just share some information with a patient versus putting in place some of these more comprehensive programs?
You know, my assessment is that speaking up about the connection between food and health should always happen. That it is the responsibility of the clinician, and just because of that relationship, there is impact. Handing out the resource material is better than the patient not having it, but all of the work I've done in years of involvement with poverty populations show that just providing somebody a name and an address or a website or a phone number does not get the job done. There are too many psychological barriers, technological barriers, time barriers, emotional issues that cloud the path to action. And we can make an incredible difference by spending just a few minutes to help people start moving on that path. Thanks.
This is Sylvia. I absolutely agree with Lynn. I think that, you know, it's a best practice to sit down and discuss any sort of paperwork you're sharing with a client, but particularly around something like food resources that has all of these complications. I mean, it is very, very complex. And as she said, people's emotional responses to it can be very complex as well. So I think that there's sort of this full spectrum of work that can be done, and I think that that at one end of the spectrum is sharing resources. Just handing out a piece of paper, probably not so effective. But as you're moving along that spectrum to sharing that piece of paper, and when you mentioned earlier that having a community health worker or someone else sit down during that conversation and enroll clients in SNAP, that would be a really effective way to carry that intervention to the next stage. And I think that that just continues on. The more in-depth you can get into that conversation, the more touch points there are for opportunity to help people around these issues. I think some of the programming that we're doing certainly is certainly has a lot of effort and money involved, and it remains to be seen how successful this is. I think that anecdotally what we've seen is that this work is going very deeply into a few people's lives and a few families' lives, but whether or not at the end of the day that money could be better spent somewhere else, I think we really don't know that yet. So I'm willing to be really open about that at this point. But I think it's been very exciting to see with these few families that we've been working with, these 25 families, how invested they are in their health by really making this commitment to 23 weeks of a program like this.
Well, and the Cooking Matters program that Multnomah County partners with the Oregon Food Bank on and is offered throughout the state is an evidence-based program. There has been long-term evaluation that shows true behavior change of people who have gone through that course, so that there are some proven interventions here, but we also need to be working to find many more.
All right. Well, thank you both to Lynn and Sylvia for coming and sharing what you guys are doing and what you have to offer in information and resources. I think everyone learned a lot, and we will get this recorded webinar, the slides, and resources that were cited out to all of you on the phone call. So thank you all very much for participating, and live long and eat healthy.
Thank you.